mentioned Golcadomide. So any Golcadomide second-line data that are exciting at the meeting? I think Loretta mentioned what I think is one of the best abstracts, the EPCOR plus R square abstract that has already been approved by the FDA. So are you guys excited about maybe extrapolating from that in the future to an agent like Golcadomide?
So Swetha already alluded to, there's some data being presented here looking at Golcadomide in combination with rituximab in relapsed refractory follicular. Now, most of those are going to be third line or later, and there's a pretty good representation of those that had prior lenalidomide, prior CAR-T, even in some with some CD20 T-cell engager prior exposure. And so right now, that's probably one of the greatest unmet needs in follicular lymphoma. Efficacy looks quite high. Again, very manageable toxicity profiles. So obviously, they're moving it into earlier lines of therapy. There's a randomized trial that's a trials in progress poster here looking at Golcadomide in combination with rituximab versus investigator's choice. And investigator's choice is R squared or R chemotherapy. So we could maybe argue that's not the most attractive control arm now. We have the bispecifics plus R squared. What I'm intrigued about in follicular lymphoma is, as in other indolent B-cell malignancies, we've been really quick to move away from chemotherapy, but chemo still has a stronghold in follicular lymphoma that I don't fully understand other than that ease of use that we can't downplay in a disease like follicular lymphoma.
And there are data from Sloan Kettering, a huge database. I'm sure MD Anderson has similar data that show that a good number of follicular lymphoma patients only require 0 or 1 treatment in their lifetime, right? So I think that's where the appeal of chemo comes in. You treat a patient, 6 months of therapy, you don't have to worry about significant toxicity, and then you can just observe them for the rest of their lives. But where do you see the advantages, Swetha, of the newer therapies over chemotherapy?
I think quality of life is important in an indolent disease. So I think chemotherapy has other toxicities like nausea, potentially more fatigue and infections. So it's, we've seen with some of the novel agents, while there is toxicity still, the infections and cytopenias, in terms of late toxicities like maybe secondary malignancies, others, we may be seeing less of those with some of the novel agents. And also, I think the idea of potentially durable, even more durable remissions. Of course, it's too early to say, but are we curing some patients with using bispecifics frontline? We know that patients who achieve a CR have very durable responses in the short follow-up. Time will tell, but the hope is that we, can allow these patients to live normal life expectancies without needing any more treatment and potentially curing their disease. So I think the novel agents, like bispecifics in particular, offer that potential of maybe more durable remissions, less toxicity.